Professor Hany Ragy is going to present the FLAVOUR trial, fractional flow reserve versus IVUS to guide PCI.
أول ترايل كده بيبقى فيها كده دكتور أشرف. أول ترايل بيبقى فيها خناقة بس كانت دي هتمشي كويس.
Dear Chairman, dear ladies and gentlemen, thank you very much and thank you for being here tonight. I know it's difficult to be inside the hall in the beautiful city of Garda, and I would like to thank Professor Ashraf Rida and the entire organizing committee, and I can see the effort in this. I've decided to present this in a way which would be suitable for our Egyptian practice, because this is a study from Korea and China, where I actually visited where Dr. Bonkon Koo works, and what they do is they actually do FFR and IVUS in every single case as a routine. So it was very easy for them to compare. I don't think the comparison is what really matters, even though it's the core of this trial, but I think the way they used it might be useful for us. This was the trial where they compared FFR versus IVUS to guide PCI, and they explain everything about FFR and IVUS. And the working hypothesis was that we know that IVUS produces excellent results. They wanted to prove that FFR-guided PCI without IVUS will be non-inferior to the IVUS-guided PCI strategy in regard to clinical outcomes at 2 years following the index procedure. So they wanted to leave the patient at the end of the, they wanted first to use the FFR to decide that this patient is indicated, and then at the end of the procedure to do an FFR to show that the patient is not ischemic anymore. And then they see. A primary endpoint was POCO, patient-oriented composite endpoint, death, MI, and revascularization. And the inclusion and exclusion criteria were very routine. All the patients who were included in this trial only had intermediate lesions. Severe lesions were not included in this trial. The criteria to do a PCI, this is one of the most important slides, was to have an FFR, if you're working on FFR, to have an FFR less than 0.8, and or if you're working by IVUS, to have an MLA less than 3 millimeters, or between 3 and less than 4 with a plaque burden more than 70%. And when you finish the procedure, you do the same modality that you used. So you call your FFR-guided PCI successful if your post-PCI FFR is above 0.88 with no gradient across the stent. Or if the plaque burden at the stent edge, if you're working by IVUS, is less than 55%. So if you have a 50% plaque burden at the edge of the stent, this is successful. And the minimal stent area more than 5.5 millimeters square, or the minimal stent area bigger than the distal reference lumen area. This is a very, very important slide. They randomized 1,700 patients, 830 in each arm. All baseline clinical characteristics regarding age, diabetes, etc., and the medications were equal. Regarding also the angiographic characteristics, multivessel disease, target lesion length, and the IVUS and the FFR findings are at the bottom here. Here on the majority of patients had a minimum luminal area 3.4 millimeter, and ended up with 7. So that's a huge gain if you're working by IVUS. FFR, they had less than 80 and reached 88. The primary outcome, there was no difference. So over the period of 24 months, the patients did well in both groups. And there was a POCO, which is the MACE, of 8.8% in each group. There were no difference in clinical outcomes in death, MI, revascularization, or stroke between both groups. No statistically significant difference. Even if the patients underwent IVUS or FFR and just underwent medical treatment based on these decisions, there was no difference. If they did PCI, the IVUS group numerically had slightly better result, but no statistically significant difference. This is, again, a very, very interesting slide, because it shows that the numbers here are very small, so they don't reach statistical significance. But there is a difference in outcomes if you reach an optimal outcome using IVUS or FFR, or if you leave the patient with a suboptimal outcome. And this has reached statistical significance in the FFR-guided arm. So it's important, whichever method you're using, not just to use it to decide, but then to use it after the procedure to make sure that you did a good procedure. There was no difference in the subgroup analysis, age, sex, diabetes, nothing. Nothing was better. And this is the per protocol analysis primary outcome. The curves are almost superimposed. As far as the patient's feeling, there was no difference regarding physical limitation, frequency of angina, treatment satisfaction, quality of life was the same. And this was the last slide. Of course, the study had a lot of limitations. The criteria which is used did not incorporate local hemodynamic significance, did not look at plaque vulnerability. There was a lot of limitations, but the conclusion is that among patients with intermediate coronary stenosis, FFR-guided PCI can be used to decide to do the procedure and then to decide the outcome. It is non-inferior to IVUS-guided PCI with regards to a composite of death from any cause, MI, and revascularization at 24 months. The FFR-guided PCI, in contrast to the IVUS-guided PCI, as you would expect, resulted in using less stents because you look at a lesion and it looks tight, you do an FFR and it's 0.9, you leave it. And there was no difference observed in patient-reported outcomes between the two strategies. So what is in this for us in Egypt? What's in this for us in Egypt is to use more imaging or physiology, whichever you're comfortable with, and whichever is cheaper, whichever is easier in your lab. If you're using both, that's fine. They are equal. And not just to use them to decide the indication, but also to use them, which is very, very important. I mean, for instance, if I'm doing FFR and I see that the lesion is 0.6, and the wire is in place, and I put a stent, I have to do the FFR after the procedure. And if the ischemia, if the lesion is still 0.7, then I have to look inside this artery, what is happening. Maybe I need to optimize my stent. Maybe there's another lesion I didn't see at the ostium or something. So it's very, very important to learn how to use these tools and to use them regularly.
Dear doctor, your time is up.
Dr. Hany, what's your opinion about المقولة بتاعت لو عندك intermediate lesion وعايز to proceed with PCI اعمل له IVUS، لو عايز ان انت تديفر اعمل له FFR.
Yeah, it's always said as a joke, but as a fact, for example, if you have left main disease and an 80% osteal circumflex, and those symptoms that are not totally convincing, in the many, many cases, what looks like an 80% angiographic osteal circumflex stenosis will be FFR negative. That is why this was said. So FFR makes you leave lesions which are going to expose the patient to risk in difficult scenarios very comfortably, with proof that the patient can be left alone for many years with this apparent angiographic tight stenosis.
So if I have a comment, حقيقة لو حطينا on the ground, يعني let's talk practically. If I want to have a decision, I would go for FFR, and if I want to have precise pre and post.
Dear doctor, your time is up.
Except for left main a little bit. Do you agree?
You're right. You're right. I mean, for the left main, I think I would go for IVUS anytime over FFR.
Sure.
But this trial, like I said, is not very applicable to the Egyptian practice. It's very applicable to the practice in Korea, where they use both. And now maybe they'll just use one. It might make their life easier. They have some data. But for us, it shows us how to use them. So for instance, it shows us that if we leave 50% plaque burden at the edge of the stent by IVUS after the procedure, when everybody in the room is telling you, "Fi plaque, fi plaque, fi plaque," it's okay. It's okay. As long as the MLA is good and it's gone up, it's like 7, it was 7 here, okay? You can get rid of this plaque at the edge with lipids, and we are the lipid people in this room.
Thank you,
lipid
Professor.
lowering therapy.
Thank you very much, Professor Hany. And I would ask Professor Ghada Hazamen.
ايه رايكم في الالتزام بالوقت؟
Excellent.
رائع.